This is Dr. Zapchinsky. This PowerPoint is about gallbladder and pancreatic disorders and cirrhosis and liver failure. The topics we'll cover in this PowerPoint are cholecystitis, acute and chronic pancreatitis, cirrhosis of the liver, alcohol-induced liver disease, and hemochromatosis and Wilson's disease. Cholecystitis is an inflammation of the gallbladder, usually from cholelithiasis, which are gallstones, also known as calculi, in the cystic duct. These stones are generally made of cholesterol, that's most common. Having gallbladder disease is prevalent in Western society. The risks are, there's a mnemonic of the 6 F's: fat, female, 40, flatulent, fertile, and fat intolerant. But after age 50, the gender distribution is equal. Pregnancy predisposes women to gallstones because of the increased intra-abdominal pressure during pregnancy and cholesterol levels that rise in the 3rd trimester. A brief review of physiology. What is bile? Bile is a fluid that is made and released by the liver and stored in the gallbladder. It is made of cholesterol mostly, bile salts, bilirubin, water, and other salts such as potassium. It helps with digestion. Primary function is to emulsify fats. That means to break down fats into fatty acids. You can see in this slide that the gallbladder is connected by a duct to the duodenum. That's the first part of the small intestines. It comes right after the stomach. Note too, underneath that the pancreatic duct empties into the common bile duct. So stones can get lodged anywhere along the pathway from the gallbladder down into the ducts all the way to the common bile duct, where blocking the flow of bile and in some cases pancreatic enzymes. Gallbladder pain is typically colicky. That means it comes and it goes, and it generally comes and goes with either the circadian rhythms or after eating. It is in the right upper quadrant or the epigastrium. Often the pain will be described as moving from that area of the epigastrium straight through to the middle of the back or into the scapular region or into the right shoulder. Sometimes these folks will be pretty sick. They will have fever from acute inflammation, complain of nausea and vomiting, and they may report their stools are pale or light colored. And that's because bile or bilirubin is blocked, so the stools don't have color to them. There may be a positive Murphy's sign. So when you're palpating in the right upper quadrant and have the person take a deep breath, there's going to be guarding or a hesitation as they try to take that deep breath because of the pain that it's caused. Labs that you'll see, WBC, there will be an elevated white count. You'll have leukocytosis with a shift to the left. Serum transaminases are elevated, the AST, the ALT, and the ALK-Phos. The ALK-Phos is a really good indicator of gallbladder cholecystitis when it is elevated 2 to 4 times normal. Bilirubin may be high. A normal bilirubin is about 1 or less than 1, and the bilirubin may be around 4. You can do an abdominal x-ray on these folks, but the gold standard is the ultrasound. It's quick, it's non-invasive, and if there's stones in there, you can usually see them. If it's iffy, though, a HIDA scan can be ordered where cholecystokinin is injected into the bloodstream and the gallbladder is viewed under fluoroscopy for the amount of squeeze or ejection fraction. Differentials include pancreatitis, myocardial infarction, appendicitis, peptic ulcer, pneumonia, hepatitis. So, depending on how sick the person looks, you can send them to an ER for evaluation. If they are pretty sick, they've got nausea, vomiting, fever and leukocytosis, a positive Murphy's sign, I'd send them on to the hospital to get a surgical evaluation. The management of acute gallbladder depends really on the symptoms and the past medical history. Do they have a history of gallstones? Is this not a new thing for them, or is this an acute attack? If it's a gallbladder flare-up, then sometimes we can settle them down and send them home, avoiding fatty foods. But there is the history of recurrence here is real. If they are not a surgical candidate, lithotripsy, which is where they use sound waves to get rid of the stones, that can be done. But typically the treatment for a gallbladder with stones in it is to have a cholecystectomy. A surgeon may tell the patient, look, it's a diseased organ and it needs to come out. Problems with gallbladders that have stones in them are perforation, when there's rupture of a gallbladder, and then adhesions that form. So the earlier you can identify it, the better. This section is on pancreatitis. Essentially, there's acute pancreatitis and chronic pancreatitis. This slide is about acute pancreatitis. About 80% of people with acute pancreatitis have a cause of either biliary disease, like we talked about in cholecystitis. They have stones in the bile duct, or from alcoholism. 25% of patients will experience a recurrence of acute pancreatitis. Acute pancreatitis is usually from a source other than the pancreas itself. So 60% is caused by gallstones and the other by excessive alcohol intake. There are some things that can cause acute pancreatitis as well, including infection, hyperlipidemia, specifically high triglycerides, metabolic disorders, and certain drugs such as furosemide. Acute pancreatitis can be mild or it can be severe. If it's mild, it tends to improve in 2 to 3 days, and it doesn't involve other organs. If it's severe, it can be complicated, involve multiple organs, and actually become life-threatening at times and put the person into shock, renal failure, and so forth. This is not something that we are going to manage in primary care. If someone comes in and we suspect acute pancreatitis, we're going to send them to the ER for an evaluation. As I said, acute pancreatitis is usually managed in the inpatient setting. Our job as primary care providers is to identify it. People with acute pancreatitis have abdominal pain, and they have it in the epigastric region, oftentimes radiating to the back. The gold standard for us is to diagnose pancreatitis is an elevated serum amylase up to 3 times normal. Lipase is not used so much anymore. Imaging, abdominal ultrasonography is non-invasive. We can also do an ERCP, and that is an EGD with a retrograde scope looking into the ducts from the bottom of the duodenum. Differentials, CT can be helpful in differentiating other abdominal processes such as the differentials we mentioned before, appendicitis, even diverticulitis, etc. Chronic pancreatitis is exactly what it says. It is something that occurs over and over again, and it is marked by chronic inflammation of the pancreas and fibrosis that occurs in response to the inflammation. 70 to 80% of people with chronic pancreatitis have it because of alcoholism. But it can also be related to autoimmune diseases, genetic mutation, heredity, hypertriglyceridemia, severe malnutrition, especially in developing countries, or obstruction of the pancreatic duct. A person who has chronic pancreatitis may come in to you and say, this is how I felt the last time my pancreas were upset. They may have intractable abdominal pain. That means they can't make it go away. Weight loss, diarrhea. They're not eating because anytime they eat, they get sick or they have diarrhea. Their stomachs are upset. they have nausea and vomiting, and they have epigastric left upper quadrant pain. Diagnosis is through the evaluation of pancreatic function and looking at pancreatic calcification. As the pancreas are constantly inflamed, scar tissue sets up, and the pancreas lose their function as healthy tissue is replaced by fibrotic tissue, and we can actually see the pancreas smaller. Imaging studies include ultrasonography, MRI, and cholangiopancreatography. Management, the goal here is to prevent further damage to the pancreas and to maintain as much function as possible. But manage pain. These are patients that have excruciating pain. When the pancreas hurts, they are sick. And so sometimes narcotics are what are needed to manage the pain. We may have to supplement the exocrine and endocrine function of the pancreas. Now, the exocrine function are those exocrine hormones that help with the breakdown of food, and the endocrine function is the insulin. So the other thing is that if the problem is caused by alcohol, they need to abstain from alcohol. This section is on cirrhosis and liver failure. Cirrhosis of the liver is damage to the liver structure, the cells. It's irreversible, and it is an end stage of result of liver injury. There is fibrotic scarring, and looking at liver cells under a microscope, the actual hepatocytes have changed. There are a number of causes of cirrhosis. At the top of the list are alcohol, drugs, hepatitis, autoimmune diseases, and diabetes. Early on, the cirrhosis doesn't have any symptoms. They're nonspecific. As time goes on and the disease progresses, people will initially complain of weakness, loss of appetite, weight loss, and fatigue. They're malnourished. They can't take in enough calories and convert those calories to energy. Advanced disease, you'll see GI bleeds from esophageal varices, sometimes from stomach ulcers. They may develop ascites, which is fluid in the abdomen, and mental changes such as encephalopathy. They may complain of liver pain or soreness over the liver area. You also see some swelling in the ankles, feet, and legs. They'll have spider angiomas or spider veining, and you'll see those across the abdomen, and they may turn yellow. One of the first people that I ever took care of that had end-stage liver disease fit that description. He was a man in his mid-50s. He was swollen from head to toe. His stomach was tremendously large from ascites, and he was as yellow as a canary. Differentials include alcohol-induced liver disease, hemochromatosis, non-alcoholic fatty liver disease or NAFLD, drug toxicity, viral hepatitis. Diagnostics include an ultrasound of the liver and ERCP. Labs, liver studies, hepatitis panels, drug tox panels, and ammonia levels. Management, identifying and removing the causative agent, treating symptoms, and preventing complications. Alcohol-induced liver disease is common. The most effective treatment is abstinence. The liver can regenerate itself pretty well. The 2-year survival rate for those that abstain from alcohol is about 95%, while the survival rate for those who do not practice abstinence is about 25% over 2 years. Nutrition is important. These people have protein and vitamin D deficiency, B12, folate, thiamine, those are the B vitamins, and then magnesium and zinc. Complications include portal hypertension, ascites. Ascites can be observed when there's at least a liter of fluid in the abdomen, and this can be assessed with a fluid wave. For ascites, we treat that with a sodium restriction, diuretics, and oftentimes we have to do a paracentesis to draw off the fluid, especially if it impairs their breathing. Hepatic encephalopathy, this is usually from increased ammonia, and oftentimes these patients will be placed on lactulose, which binds the ammonia, and then they excrete it through the bowel, or neomycin. Anemia from iron deficiency and hemorrhage are complications. Hemorrhages can be managed in a number of ways if they are caught early enough. Sclerotherapy, these are usually the result of esophageal varices, and sometimes sclerotherapy can be helpful. Other times they have to have surgery. Look at box 42.2 in your text for some treatments of the other complications. Hemochromatosis and Wilson's disease are two inherited diseases of the liver. They are treatable. Hemochromatosis is an accumulation of iron in the liver, and Wilson's disease is an accumulation of copper. Hemochromatosis is verified by measuring the serum ferritin levels and by doing a liver biopsy that shows liver full of iron. Now, we measure the serum ferritin, which is a storage of iron in the liver. A normal serum ferritin is less than 100 nanograms per milliliter. Hemochromatosis is present if the ferritin is greater than 300 in men and 200 in women. Also, genetic testing can reveal the variant, the HFE-C282Y variant that is associated with hereditary hemochromatosis. The treatment for hemochromatosis is weekly phlebotomy. That means drawing off 500 mils of blood until the serum ferritin falls below 50 nanograms per mil. Then after that, phlebotomy as needed. So these patients need constant follow-up. Wilson's disease is a disease of copper accumulation in the liver. Early detection can prevent development of neurological or hepatic damage. Treatment includes dietary and medicinal regimens. First, there's a low copper intake. Some legumes are full of copper. Also, animal organs and shellfish. Those need to be avoided for life. Oral penicillamine or D-pen, 0.75 to 2 grams per day. That's 0.75 milligrams up to 2 grams per day to induce urinary excretion. So what it does is it chelates or binds to the copper in the blood, and then it's excreted through the urine. Now, penicillamine is an anti-metabolite of vitamin B6, and they become deficient in that, and so we'll need to supplement pyridoxine 50 milligrams per week. Also, they'll need oral zinc 50 milligrams 3 times a day as a maintenance.